My name's Nabeel Azeem. I'm from the Mayo Clinic in Rochester, Minnesota, here to discuss our case series published in this month's issue of Gastrointestinal Endoscopy entitled Cholangioscopy Using Narrowband Imaging in Patients with Primary Sclerosing Cholangitis Undergoing Endoscopic Retrograde Cholangiopancreatogram. As we all know, there's an increased lifetime risk of cholangiocarcinoma and primary sclerosing cholangitis. Thus far, current modalities for early detection of dysplasia in PSC patients have had limited sensitivity and specificity. Recently, high-resolution video cholangioscopy has been introduced, which also allows for the concurrent use of narrowband imaging when visualizing the biliary tree. In our study, we evaluated the use of a prototype cholangioscope with NBI capability manufactured by Olympus for the early detection of biliary dysplasia in patients with PSC. The prototype video cholangioscope is a 2.3 meter long endoscope with a diameter of 3.5 millimeters and a working channel size of 1.2 millimeters in diameter. It utilizes a mother-daughter system with a standard duodenoscope, and the image quality is significantly improved over fiber optic cholangioscopes. The study was a 2-year prospective single-center evaluation that enrolled PSC patients that required an ERCP for diagnostic or therapeutic purposes. The ERCP was performed in standard fashion. The cholangioscope was advanced into the biliary tree and first examined under white light. NBI was then turned on and the biliary tree was re-examined. Lesions suspicious for dysplasia were documented and biopsies were taken under direct visualization. Fluoroscopically guided biopsies and brushings for cytology and FISH were also obtained. Patients were then followed for about a year. 30 patients were ultimately enrolled in this study. At the end of the study period, 4 patients ultimately had a diagnosis of confirmed cholangiocarcinoma, 2 intrahepatic and 2 extrahepatic. However, directed biopsies obtained with the cholangioscope with white light and NBI did not increase the detection rate of dysplasia in this cohort compared to fluoroscopic guided biopsies and brushings. The introductal visual appearance of the PSC patients under white light and NBI was quite variable in the study, and it was difficult to correlate with dysplasia. This is a population with underlying disease causing significant biliary mucosal changes, and with patients that have likely required prior biliary stents, all of which distorts the mucosal architecture, making it difficult to differentiate dysplastic mucosa from inflammatory mucosa. Although NBI resulted in the biopsy of 48% more suspicious lesions compared to white light, no increase in dysplasia detection was seen. However, in both patients with extrahepatic cholangiocarcinoma in whom malignancy was confirmed through other modalities, examination with NBI cholangioscopy helped identify the hypervascular tumor margins despite negative directed biopsies, which also has been demonstrated in other studies. One reason why cholangioscopic directed biopsies may have been negative in these case series is that the working channel exit of the cholangioscope is parallel to the imaging lens, and the restricted mobility of the cholangioscope tip can make it difficult to biopsy the exact area of interest. The main limitation of this study is its small sample size. Additionally, video cholangioscopes that utilize a mother-daughter system have had a tendency to become damaged as the rubberized bending section exits the elevator of the duodenoscope. We unfortunately did not record this data prospectively during our study, but looking retrospectively during the study's time period, 5 of the prototype cholangioscopes were damaged and required repair. And finally, the Olympus prototype cholangioscope used in this study is not currently commercially available in the U.S. I think this study adds to the growing literature about video cholangioscopy, which has primarily been done in non-PSC patients. Additionally, very few studies have utilized NBI using cholangioscopy in this population. In this small case series, while no increase in the detection of dysplasia using per-oral NBI video cholangioscopy was seen, NBI was useful in defining the distal tumor margins in PSC patients with cholangiocarcinoma. PSC patients are at considerable lifetime risk for cholangiocarcinoma, and current methods for early detection are less than ideal, which is why further investigations into per-oral video cholangioscopy is warranted for the early detection of dysplasia in PSC patients. I would like to thank my co-authors, Dr. Christopher Gestout, Dr. Todd Barron, and Mary Nipshield, for their work on this study and their expert guidance throughout this entire project. We appreciate the opportunity to have this article featured in this month's edition of Gastrointestinal Endoscopy. Thank you.